Hello and welcome to Tennessee HFMA webinar. I'm Pam Jones. I'm the co-chair of Programs and Education, and I've got a few announcements before we get started. We've posted the slides on our website, and you can also find the link in the GoToWebinar chat box. We have a few upcoming events. Registration will be open shortly for our next webinar, Value-Based Contract Management. It will be held on February the 9th. And you can visit tnhfma.org/webinars for more information. Our Tri-State Institute is fast approaching, and you can register now, and it will be held January 27th through the 29th in Memphis, Tennessee. Visit tristateinstitute.org for more information and to register. And registration is now open for the Dixie 2016 Institute, which is entitled Harmony in Healthcare. And this conference is designed to support HFMA's commitment to providing programs that enhance the growth and development of its members. And this annual conference brings together HFMA members from 5 different states, which included Alabama, Florida, Georgia, South Carolina, and Tennessee. The conference will be held on March 20th through the 23rd in Nashville, and you can visit hfmadixie.org/2016 for more info. And registration also will be open soon for our payer summits that will be held March 8th through the 10th in the Tri-Cities, Knoxville, and Nashville areas. And each payer will discuss current issues and trends with their respective programs, as well as upcoming changes and initiatives. And if you would like more information about that, you can visit tnhfma.org/payer summit for more information. And just a reminder of the requirements for the CPEs, you must be connected to the webinar for at least 90% of the duration, and you must respond to at least 2/3 of the polling questions. And now I'd like to introduce our speaker, Teresa Copeland. She is the Director of Managed Care Contracting at Knoxville Orthopaedic Surgery Center. It's a 50+ physician group with 9 practice locations and physical therapy, orthotics, and MRI services. With more than 38 years of experience in the orthopedic practice management, Copeland's expertise spans all facets of the practice, including clinical, billing, and collections, contracting, and facility startup. In her current position, she is responsible for managed care contracting for the physician practice and the ambulatory surgery facility. She also serves a wide variety of other roles, including the billing and collections and operations consultant, the risk management for property and medical malpractice, the supervisor of the MRI department, and the construction liaison for 3 new practice facilities and 1 ambulatory surgery facility. So at this time, I would like to turn this over to our speaker, Teresa.
Good morning, and thanks for joining in. I'd like to take an opportunity to tell you a little bit about our center. We're speaking specifically today about the practices at our Knoxville Orthopaedic Surgery Center. It's a physician-owned musculoskeletal ambulatory center. It was developed and built by a group of physicians from our orthopedic practice. We opened in January of 10 with 4 ORs and 1 procedure room. We had shelled out 2 additional ORs, which we opened in the spring of 13. So we now have 6 ORs and 1 procedure room. All of our physicians are orthopedists or musculoskeletal, and we were on target for 9,000 procedures in 2015. That's about 56% ortho and 44% interventional pain management. We just got our data for 2015, and we were just over 9,600 cases. I think the important part for us, what makes our life good and what makes our life complicated in our center, is that we're physician-owned. The physicians developed the center so that they could have control over their schedules, over what they used, over how it was managed, over the efficiencies. They're all subspecialized. There's a high acuity of cases because of that, and they all like what they like. They like their high-quality, specialized products, and we try to accommodate that in every way possible. Our high volume means that we're always busy, and that's the way we like it, and we're very thankful for that. But that means that our limited number of staff are extremely busy and need to have efficiency. For me, I think that this statement sort of sums up, we try to manage the middle. Our challenge is to maintain a high-quality, patient-centered facility, managing individual physician preferences during this time of decreased reimbursement and increased patient responsibility. We're all facing CMS and commercial payer bundles and payment policies that reduce our reimbursement. At the same time, we're seeing increased deductibles, co-insurance, and co-pays. We're in our center routinely seeing $2,000 to $5,000 deductibles. That means that there's less reimbursement coming from the payer and more of the money, the patient responsibility. So I think that it's really important that we collect as much as we can as soon as we can. In our center, we've really tried to put a focus on from the moment that case is scheduled through final payment. And we do that by verification of benefits, estimation of patient responsibility, collecting at the time of service, timely claim filing. Then we try to manage the billing and collection in a timely and efficient manner, and denials management, which is something that we have just recently embarked on, trying to do a better job of our denials management. I think at this time it's time for our first polling question.
Okay, the first polling question is, all of the following are important to collecting timely patient reimbursement except estimation of patient financial responsibility, verification of benefits, patient registration time, timely filing of clean claim, and denial management. And just a reminder, we do need, in order to gain the CPEs, you do have to answer 2/3 of the polling questions. I'll give it just a few more seconds before I close that. Okay. Okay, Teresa, it looks like 87% chose the patient registration time as the correct answer.
I would agree. Thank you. Moving on, I think that for us, staff and space are costly. I think that that's true of any organization, no matter the size. We are a physician-owned, one-location surgery center. We have minimal staff. We have minimal space. But I think that if you're bigger, it's just the same thing on a bigger scale. Our practice has 10 locations. We have a large staff, and we have the same issues. Staff is expensive, benefits are expensive, and we have no place to put staff. Having additional space for offices is always a challenge for us. So, and I think over the past several years, we've seen increases in on demands on staff, electronic health records, increased payer requirements, reporting requirements. We have, in orthopedics, we have a lot more pre-cert requirements. We have a lot more staff to try to manage that. There's more required in claims management with bundling and payment policies and new edits. And so our staff has a lot more demands put on them, and yet it's not efficient for us to just add more people to the mix. So we have to figure out how we can work smarter. Our goal is to continually review our processes and work with our partners to equip our staff to work more efficiently. I think that we're definitely a work in progress. We don't have all the answers. We started out, we've just finished our 6th year. We've worked throughout that time to try to review our processes on a regular basis to see how we might improve that. I think we're moving more into every day, every year, into a situation where that's becoming even more true in the alternative payment environment. There's accountable care organizations and comprehensive primary care initiatives and bundled payment in a multitude of ways. There's the BPCI, which our center participates in. There's comprehensive joint replacement, state initiatives, commercial payer bundles, employer, direct contracting, municipality bundles. We're all looking at alternative payment methods and how we're going to manage that environment. Health and Human Services, I saw this on the CMS website recently. They have set a goal of tying 30% of Medicare fee-for-service payments to quality or value through alternative payment models by 2016 and 50% by 2018. They've also set the goal of tying 85% of all Medicare fee-for-service to quality or value by 2016 and 90% by 2018. Clearly, our commercial payers will follow suit. So I think we're looking at even more, I guess, more of the same over the next couple of years while we all try to ramp up on how we're going to manage this process and how our reports are going to work and how our software is going to work, and we're all going to be looking at that, which all of that just brings more expense to the table for our practices and facilities and busier employees, so we've got to learn how to just continue to work smarter. This means that someone will be at risk for the majority, if not all, of the entire episode of care. The accountable care organizations, the bundled payment arrangements, we are taking on risk at some level that we are then having to pay out of our pocket to other providers. So it's critical that we collect in a timely manner prior to when we have to distribute dollars to other providers. I think we'll spend a little bit of time here on the eligibility, and I think we try to get it right from the very beginning. We're not always successful, but we've put a lot of work on the front end in trying to get it right to reduce the work and time delay on the back end. We start with eligibility verification. Some of the changes, I'm going to sort of go into how we used to do it and how we've kind of moved into doing it over the last, probably this has been about a 3-year process for us, still moving forward, still learning, still tweaking. But in the beginning, we used multiple payer websites to verify patient benefits. This was very cumbersome, very time-consuming. We have one staff member primarily that does all verifications, and so the more she had to move around, the more cumbersome it was, the more time-consuming it was. Now we have a software product that allows us to utilize one product for almost all verifications. It's one site for most payers, and it just makes it much more time efficient for our staff. The next step for us is patient estimation. I feel like that the patient deserves to know what's going to be expected of them. I would sort of call this my own personal golden rule, because I want to know when I'm going into even an office visit, but particularly for any type of procedure, I want to know what's going to be expected of me. I have a life and I have limited funds, and I have to try to manage that in my situation. I had a relatively minor procedure this past summer, and I was baffled by the fact that neither my own insurance company or my physician's office could give me any information about what my expected cost would be. I managed to kind of figure out closely what I knew what my deductible was, I knew what my co-insurance was, I had some general idea, but I work in it every day, and it was still difficult for me to come up with what an actual dollar outlay for me was going to be. And I think if we expect patients to pay us and to pay us timely, it's on us to give them information about what that expectation is. More than 90 million adults, according to the National Institute of Health in the United States, have a low health literacy. And that's just specifically speaking to understanding their health care, understanding their insurance and their physician and what the physician is telling them and what it means and what the process will be and what the expectation of time is. And I think we really wouldn't be shocked by that. It includes the cost of care and the expected patient responsibility. This is actually from a 2006 consumer attitude survey with Great West Healthcare, but I've always found it to be interesting, enlightening, and I still sort of agree that we're probably in that same boat. And 5%, when consumers were asked about pricing, they were off 5% on a Honda Accord, because we see it all the time. It's on the commercials. They have the price there. We have a real good idea of what a Honda Accord is going to cost, but they were off 50% on a routine doctor's visit because it's all over the board. It's different everywhere you go. Contract rates are different. It's just impossible for a patient to know. I would say that remains true today, even though this is from 2006. There's more information available out there today. Unfortunately, a lot of that information I find to be confusing and misleading. There's a lot of internet sites that you can go to and put in what your expected cost should be, but it's so much only a piece of the puzzle. It's very often very inaccurate information. And so I feel like that the conversations that we have up front with patients about their expectation and their patient responsibility reduces the confrontation on the back end, which reduces the stress for both our employees and our patients. And I feel like the overall patient experience is highly influenced by the financial aspect of care. Certainly, they need to have a good outcome, but we're lucky in our environments in that we have a lot of highly qualified physicians, and you can get high quality care in multiple locations. But I think that the whole patient experience is significantly influenced by the financial aspect and how much we communicate and how well we communicate with our patients. So previously for us, and in an orthopedic environment, it's varied by procedure. Implants play a huge role, and I know there are a lot of other specialties that are in the same boat where, you know, it's not just one cost for one thing. So what we did was created what we called the White Book. That White Book got used a lot, cussed a lot. It was sort of our go-to Bible for our patient estimations. And we ran a lot of reports and sort of developed by CPT, by physician, by payer, what our average reimbursement was. It was better than nothing. It was quicker once it was developed for our staff to use. The problem was that it was static. It wasn't flowing with any change in our in payment policies or in contracted rates. We would have to run new reporting, so it was time-consuming to update. We would notify the patient usually the day before the procedure, and then the patient was given just a generic document that said this is what we estimated their expected patient responsibility to be. We have a new process in place now. We're working with our software vendor where we are developing an estimation based on the most recent claims by that payer, MD, and CPT code. So essentially, we're getting the information back from the remits from our clearinghouse as to what was the average when that was a primary procedure, what was the average cost across multiple procedures for that physician or that payer. It's difficult to capture all the CPT codes and implants in the cost estimate for us because we have a lot of multiple procedures and implants can vary so much. So an average, frankly, is about the best we can do. We don't know going in exactly how many implants are going to be used, and so we work hard at getting that average. So what we're working with now is our vendor to get a total claim allowable based on the primary code as opposed to the line item level. So if we can take the total claim when that was a primary code and look at a big enough volume of claims, we have been getting a pretty good overall average. So that's the way we're working it today, and definitely still tweaking that situation. Here's basically the steps. It's 4 steps. We create and verify the patient's eligibility. We do a review of the benefits, and we complete an estimate, and then hopefully we collect our money. This is the form that we're using, that it's relatively easy to understand. It's a more professional looking document than we had used previously. It gets a lot more buy-in from our patients because it really tries to zero in on the fact that we have looked at all the factors. We've looked at the total cost of the case. We've looked at the insurance adjustments. We've looked at their copay and co-insurance and the remaining deductible, and we don't get it perfect all the time. There's claims coming in that alter that every day on the patient's insurance side, but we get it as close as we can, and we get as good a buy-in as we can from our patients because we give them a relatively professional-looking document. We've tried to put a lot of emphasis on collecting at the time of service. We're also doing this at our MRI, our DME, our prepayment on our surgeries. We just feel like that collecting at the time of service is the way we have to go because of so many dollars that are going to patient responsibility. Previously in our surgery center, we attempted to contact the patient by phone the day prior to the procedure. Unfortunately, often we had to leave a voicemail and had no opportunity to actually have conversation with that patient. So it would come down to us calling, leaving a message saying, we've estimated that you owe X and we need you to bring that with you tomorrow. And then when they would come in, they may or may not agree with us. They may or may not bring their money. They would attempt, once they were in the facility, to make an arrangement, and we would attempt to get as much money as we could related to our estimate. And at that point, it's really a bad time to try to make any changes. You know, you're either turning people away, which is messing with everyone's schedule. It creates a very bad PR, and certainly that was not what we wanted to do. We would have our patients sign a prom note for any balance remaining on the estimate, and frankly, they're only as good as anybody wants to pay attention to them. And then the patient was billed after insurance payment, and often we fell behind other providers, particularly anesthesia and pathology. So we would get our bills or our statements to the patient out the door after our insurance had paid. Now we contact the patient at least 2 days prior to the procedure, sometimes as much as 5 days prior. In orthopedics, we don't always have that benefit of having that much notice if it's a more emergent, but obviously we're working with those patients in a different way as well. We discuss the estimate with the patient. It gives the patient an opportunity to call us back if we call them 2 days in advance, and then it gives them a chance to get home that night, get the message, give us a call back. When we have them on the phone speaking with them, we request payment. We go ahead and set up our payment plan. We set up our payment plan in advance if we can, and then on the day of procedure, we follow up with collecting any remaining payments or setting up payment plans as needed. Anything that we can do in advance of explaining the patient responsibility, having the conversation about copays, co-insurance, deductibles, there's a lot of education there. And so any of that we can do in advance of the day of the procedure, and any payment arrangements, either going ahead and collecting that payment or setting up payment plans, significantly reduces the time that our admission staff spend with the patient on the day of the procedure, which again impacts their patient experience for the whole process, in that they arrive they get onboarded, and then they get follow through to their procedure in a more time-efficient manner. I think it's time for our second polling question now.
Okay. The second polling question is, at what point in the patient scheduling process did Knoxville Orthopedic Surgery Center find most beneficial to talk with patients on the phone about their financial responsibility? A, 2 weeks before the patient's appointment. B, when the patient was checking in for his or her appointment. C, when the patient called about their bill. D, never. Or E, 2 days before the patient's appointment. And I'll give it just a few more seconds and just remind you, in order to be eligible for the CPEs, you must respond to 2/3 of the questions. Give it just a few more seconds. We still have people responding. Okay, and it looks like 81% got 2 days before the patient's appointment.
That would be accurate. That's our goal, and we're pretty much standard on that. Like I said, sometimes we get way ahead and we get a few days further out than that so that the patient has more opportunity, but at this moment we're about 2 days out. I think that leads us into ease of payment. Patients are beginning to utilize more and more types of payment methods. Some recent studies have shown that 3 out of 4 consumers use at least 2 bill pay methods each month, and half use as many as 3. Consumers want opportunities for credit cards, ACH, debit cards. They want to be able to pay on a website. This is, again, just as a personal issue. It really irritates me when I cannot go online and pay, because I'm usually paying at either 7 o'clock in the morning or 10 o'clock at night, and my work day doesn't offer me easy opportunity to stop and call, and I kind of don't write checks anymore. And so for me personally, I look for the opportunity to be able to go online and pay, and I think that, you know, we expect others to sort of be in line with us, and so it was a real focus for us to try to look for the opportunity to do that. Previously, we did not have an option to go online and pay, and about 2 years ago, we put that into place, and it has been really, really big for us. We now can take money in the office, over the phone, in the mail, online. We have the opportunity to do it through the bank. We do not at this time. Previously, on our statements, patients had the opportunity to either mail us a check, to write their credit card information on that statement. I know we've all seen that. I can't even imagine that that's a good idea for us to be doing, but we were. And or the patient could call in and give us their credit card information, and we would routinely have people, in lieu of being able to make a payment plan, would just call us, you know, the 10th of the month and give us their $50, $100 payment. That I did not feel like it was very secure for our end, because we either had that patient's information on a piece of paper that we would put in the shred box, or we would jot it down, and it would be require us to manage it securely and appropriately, and we just didn't want to be in a situation where we would be accused by anyone, so we try to limit that, that security risk. This is our payment entry screen. If you'll notice, at the time of service or by phone, our staff can do a single payment. They put in the patient information, they put in the email address, they put in the payment type, and it's pretty simple. It takes just minutes. Or at that same time, when the patient calls, if they call after the fact, when there's a balance due, or this is the same process that we would follow on our end on the front end, we would be able to offer the patient a payment plan that would take X dollars over the course of several months we try not to exceed 6 months if possible, unless there's some extenuating circumstance. So we would create this information. It would create a payment plan for the patient, and every payment, whether it's a one-time payment or payment plan, creates this patient receipt and has an opportunity for us to email it directly. So we're collecting all of our payments. We're posting all of our payments. The patients, when they go online and post the payment, are posting into one site so we can run our reports easily. We have all of our information collected into one site, and when we put in a payment, it automatically gives us the opportunity to email that patient their receipt. This has been very well received by our patients that make a payment when they come into the center, or even those that do it at home prior to. But when they come into the center, and we can automatically set this up to email it, we can hand them a piece of paper, but day of procedure, they're getting all kinds of paper. They have their little booklet, somebody with them's keeping up with part of it. They go through discharge, they get discharge orders. They come out with a lot of pieces of paper, and they may or may not be able to put their hand on that payment receipt when they need it down the road. If they have a health savings plan or some other type of cafeteria plan that they want to request their money back from, then they have this in their email, and it's a lot easier for them to access, and we get a lot less calls back for people asking us to send them copies of where they have made payments. This is an example of a patient. On the left, the patient has made a payment plan. You'll see that it's got the dates that the dollars are going to be taken out. It's a recurring payment that comes directly from that credit or debit card or electronic check that they've given us. And then an example of the statement that shows that payment was posted without really any interaction with that patient and our staff, or the patient for that matter. That payment posted and they had to do nothing, and they're making their routine payments. We also recently, personally, I think there's a little work that can be done on our statement, but recently we completely removed those little boxes up there that have Visa, MasterCard, and writing in your account number and writing in your credit card number. We do not want that, as I said earlier, for security reasons, and it's just more time consuming. They've mailed something that they could go online and do. So we completely removed that from our statement and just direct them to go online to make that payment. So for our statements, for about 3-4 years, we printed our statements. Obviously, we started out initially in 2010, and we were ramping up, so we didn't have a lot of statements the first year or so, and then it began to ramp up where we're into about year 3, and we're doing about 800 statements a month, and we would print them and stuff them and mail the paper statements, and it'd sort of be all hands on deck. We have 6 people in our business office. We have a receptionist and 2 specific admissions people, 1 payment poster, 1 insurance claims charge poster and claim follow-up, and we have the person who does the primary estimation and verification. So we don't have a large staff for sure, and so what we would do would be print our statements, and then everybody would just grab a stack and stuff them, and we'd get them out the door. And of course, we had our expense of the mailing associated with that, and we really, as I said before, didn't have any payment options for the patient to make a payment. They had to mail a check or send their credit card information, and it really wasn't patient-friendly at all. So about 2.5 years ago, we started with electronic statements. We upload those. We are currently doing it monthly. We have the opportunity to do it more often, but frankly, it just seems like that the time outweighs the benefit for us. Patients can go online and set up and request an electronic delivery, which they get via their email, and they get it obviously instantly. If they don't go online if they choose to do that, if they set it up that way and then they just don't open the email, it will drop them a statement. But obviously it's much more cost effective for us if they have set up their email delivery. We do offer them that at the time they check in. We give them information that shows them how they can go online and set up their e-delivery and access their patient account and make their payments in that way. One of the things that we have really enjoyed is that our electronic statements are bumped up against the national change of address and the post office databases. And so we don't get a lot, but we get probably between 5 and 8 a month of address changes. That's primarily what we get, where it gives us the old address and the new address. And so it particularly benefits us in the unfortunate event that those balances have to go out to a collection agency because they already have more current patient information, or at least the most current that we have. We've also activated logic to send separate collection letters to the patients. So there's logic in the statement system that says if there has been no patient payment made within 90 days, they get a letter, a specific letter, a different letter than the statement, saying they have 7 days to contact our office and make a payment, or they will be turned out to collections. And that has really lightened the load for our staff, because previously that was a much more manual review process of those statements and of the accounts, of the self-pay accounts or the patient balance accounts, to see who hadn't made a payment and who needed to go out to collections. And then the patients being able to pay online, that's via a link on their statement that we saw earlier. This is another survey from 2012 that shows the number of people. 73% of households paid a bill online last month, and I think that's definitely growing from the number that pay a bill that pay all bills online. This is our website. The Make a Payment button is on every page of the website, so that any page that they happen to land on, they push the Make a Payment button. Can't hardly miss it. It brings them to a screen where they put in their information, and obviously it's taking them away at this point from our website and taking them to a secured site, but it's seamless. It looks like our site, and they make their payment there. It's easy for the patients. They can do it at any time of their choosing. This is just an example of a report that we run. Shows our e-commerce transactions. This was a specific day, transactions for in November. And I brought it up to note that there was a payment made at 7:44 a.m., which was before our office opened. But there were also 5 other payments that were made during our office hours. But because the patient went online, made that payment, even though our office was open, it was easy for the patient to go on at their convenience, their break, their lunch hour, between running kids to school or other doctor's appointments or whatever's going on in their world. It's easy for them, but it was also great for our staff because we have one payment poster. And that payment poster did not have to take time to have the conversation with this patient and capture the patient information and post it. So even if you considered 5 minutes a phone call just off of these, these few entries on this one morning, our payment poster regained about 30 minutes into her day just for not having that phone conversation, not being interrupted. We all know, especially you're doing something like payment posting, you sort of get into the flow of it, and those phone calls are extremely important. We certainly want to answer when the patient calls. We don't want them going into voicemail and then us trying to capture them later. They called us when they had a minute, and if we can't get to them right then when we've got a minute, they may not have, and they may not be accessible. So it's disruptive to our payment poster to have to answer that phone, but we certainly want to capture the patient calls when we need to. So I think that, the easier it is for a patient to pay, the sooner that you will be paid. In the old days, it was, and still today to some degree, I see it with physician office billing, but I also see it with a lot of other type of vendors. There's an envelope. There was a return address envelope included with your statement. The idea there being if you don't have to go search for an envelope, especially if it's postage paid, you're going to make that payment a lot quicker. I think the same would be true, and even more so when the patient has the opportunity to make that payment at their convenience any time of the day or night. And I think that there's just so much time lost. I know there is in my world and in my household if that statement's laid to the side because you have to go find a check, find an envelope, find a stamp, which frankly at my house is scarce and almost unheard of. So I think it's very important that we move into the age of our patients. The sort of next step of that would be claim filing. Previously, almost all of our commercial claims were paid through or were filed through our clearinghouse, but our workers' comp claims were not. Our workers' comp claims were paper because they had attachments, and so we really didn't have any good records. We knew we had sent a claim out the door. I know everyone's experienced this. We knew we'd sent it out the door, but when we followed up 30, 60, 90 days later, they didn't seem to have a copy of it, and so we sort of start the meter over. We did not a lot, but a fair amount of paper claims that were printed and mailed, secondary claims and other things that were not going direct through our clearinghouse. And only a portion of our commercial remits were coming back through the clearinghouse. And we had other remits, like other major payers, that we were going to their separate sites and downloading the payment information so that we could post. Now we have all of our claims going through the clearinghouse. We have edits that stop our workers' comp claims so that documents can be attached, but we do have then record of when those went out the door that impacts our timely filing denials. Claims are dropped to paper by the clearinghouse if that's necessary. And we're receiving almost all of our remits through the clearinghouse. We add those on as needed or as available. So the balance is resolved through the patient responsibility much quicker. For most of our major payers, from procedure to insurance payment is about 9 to 15 days. Clean claims are getting out the door. We know immediately. If we obviously don't know every edit and every possible thing that can be denied or rejected, but we have edits in the clearinghouse that stop it pretty quickly for us to correct if there's something like an ID number that doesn't have enough digits or a date of birth mismatch or some of those things that potentially cause a denial on the back end where we've lost 30 days of time for the claim to get to the payer and then to be rejected or denied and come back to us, and then we start over. So we're seeing it to be a lot more time efficient for our staff and also removing some timely filing issues. For denials management, like I said, we've got two people downstairs. We've got a payment poster and we've got a claims insurance follow-up collection person. Obviously, if you're in a bigger situation, you've got a lot more people, but I think that our issues are pretty much the same in that it's a paper-intense process if you don't have some kind of electronic software or program to help you manage it. Our payment poster identified the problems at the time of posting. If it was a claim denial or a line item denial or a variance from expected, luckily our practice management system identifies our expected based on the contract it was the charge was entered on, so it gives a pretty immediate look at if we varied from our expected. The same was not true at our practice. At a practice, the payment posters didn't know what the expected was because we didn't do the write-off at the time of charge entry, and the adjustments were done on the back end and based on the insurance remit. And so the payment posters were not in a good position to be able to identify whether or not that actually was paid to contract. And it was only in those situations where something looked glaringly wrong that they often caught the problems. So we do have software at the practice that also identifies, are we being paid appropriate to our contracts, because it's just not possible for them to pick up on that. It's not possible if we get a 3% increase. They don't know when that happens, and they don't know that it should have gone up 3% and that what they're seeing is not accurate or appropriate. The poster was responsible for following up on some of our denials. If there was a no auth or a need for medical records or medical necessity, our payment poster would follow up on that. That was sort of the division that we had inside our own process. And then the payment poster would make a copy of the EOB and pass it along to the collector to follow up on variances or other full claim denials. That was a very, a very paper intensive, voluminous process. It created piles and piles of paper, which is stressful. It's stressful for your employees to just be surrounded by piles of paper that they're trying to work through. I think it's just an overwhelming feeling when you're in that. We had to create a lot of voluminous reports to work, and we could slice them and dice them a little bit. We could slice them by payer or by time or by dollar, but we sort of had to run the report one way and then sort of rework it. We had limited abilities to sort that, and we had limited abilities to manage our workflow because it just was one employee passing something off to another employee, and she either got it and took care of it, or it went to the bottom of the stack, and that sort of depended on how easy is it or how hard is it. Our goal of 45-day follow-up often was not met because of this, just the volume of paper and the cumbersome nature of the process. Today we're using a denial management software. We use one through our clearinghouse. There are a lot of them out there. A lot of the different clearinghouses offer some sort of product. The denials are grouped by reason. We set those reasons up. We established our own work groups. We just had 2 people, but we were able to bucket the work by our collector or our payment poster. In the past, like I said, it kind of just one person's responsibility to pass something off to the other person, and sometimes that created strife about, is that my job or is that your job? We've set very clear rules that bucket the denial. No one's guessing who's responsible for it. It goes into my bucket or it goes into your bucket, and everything in my bucket's mine to work. We have the ability to sort it in many, many ways. We can sort by reason, by payer, by amount. It improves our productivity. We avoid timely write-offs by nothing really falls through the cracks. It captures all the denials and puts them through into a bucket. Now, that they don't work themselves. Somebody's got to work them. So that's not to say that nothing could fall through the cracks, but we certainly have the opportunity to run reports and to identify if something is falling through the cracks, where and why and who. We have a dashboard, which makes it great for management because we can look at a glance and see who's got what in what bucket. We have the improved ability to track and report on the progress. We can see, one employee is working, she's keeping her buckets clean, and the other one's letting her buckets pile up. And then that's not to say that the other person isn't working hard. It just gives us opportunities to re-look at the process and see, do we have things divvied up appropriately, and do we need to re-look at where some of that work, where that's falling. And I just think that the transparency improves accountability. If I know it's my responsibility, I am absolutely accountable for it. I know that people are looking at it and they know I'm responsible for it, as opposed to everybody's responsibility is sort of nobody's responsibility. This is an example of our denial management dashboard. We have it bucketed by our designs. We can track it. We can report on it in a lot of different ways. For me personally, One of the benefits, I think, of this is being able to batch your work and work your work in an efficient way. We can work it by batch. I could say, I want to see all the Aetnas that denied at line item for this reason, and I can file an appeal on those in one, sort of click of the mouse. I like to see the work bucketed. This is probably just my personal way to work, but it's sort of like eating an elephant one bite at a time. If I can divide my work into workable amounts, then I can see the benefits of my work more quickly. I can see that I'm getting somewhere, as opposed to the reports that we used to run, which were many page reports, and you would just work and work and work and work, and you may or may not get through the entire report until the next 30 days when it was time to start over. And do we work the high dollar balances and capture those because they're important? But then if we've got just a CPT code or two that are not being paid correctly, they're not high dollar, but we're losing $50 a pop, and we're losing it 20, 30 times because it's a pretty common code. It's not a $500 loss, but it certainly adds up to that quickly. In this way, we can batch that problem and we can get it out the door in an efficient way. I think it's time for our third and final polling question.
Okay. The final polling question is, Knoxville Orthopedic Surgery Center did all of the following to improve their denials management strategy, except A, establish denials work groups, B, group denials by reason, C, have all the claims go through a clearinghouse, D, ask the person who posts the payments to identify inaccuracies, or E, utilize a dashboard to see the denial status as a glance. And I'll give it just a few more seconds. Just final reminder, if you do need the CPEs in order to be eligible, you do have to respond to 2/3 of the questions. Give it just another couple of seconds. Okay, it looks like the biggest majority chose ask the person who posts the payments to identify inaccuracies.
Okay. I think this brings us near the conclusion of our processes and what we've worked on over the last couple of years to work with our partners and with other software to figure out how we can work more efficiently. I think in the end, our staff has really embraced the processes because they have to move around less in a lot of multiple sites. It makes their day, they can manage their days a little bit better. They're able to give more professional documentation to the patient, which gives patient confidence. And so when they have conversations with patients, they tend to go better and they feel better about them. Our payment posting has become much more efficient, and the division of the denials into the work groups has improved the workflow and the ability to track the work in a better way. I think our patients, we've gotten really good feedback from our patients. They seem to love it because they get more timely and accurate estimations. I think that patients deserve to be informed. I mentioned that earlier. If we're going to ask the patient to pay us, and we're going to ask them to pay us in a timely manner, they deserve to have an understanding of what that expectation is going to be, and they deserve that on the front end so that they can make an informed decision going into the process, whether it's a test or a treatment or a surgery, just office visits. They need to understand what portion is going to fall to them. I think too often in the past, our answers were, we'll file your insurance. And today, that just isn't good enough because we will file their insurance, but unfortunately, more and more and more is still going to fall to that patient responsibility. So they need to be prepared for that. They're getting documentation that they trust more and believe more in. They certainly embraced the ease of payment through the online and other options. And they get faster resolution to their claims, which I think is their expectation as well, because when they had a procedure, 2 months ago, and they still haven't been told what their portion is, the further out we get from really letting them know what their remaining balance is, or that it's been settled and done, or a refund back to them. If we've overestimated, they deserve that refund back in a timely manner. So I think that we have all benefited from having the process work more efficiently. That's all I have, and I appreciate your time this afternoon. If there are any questions, we probably have just a couple of minutes for that.
Teresa, we do have 2 questions so far. Okay. The first question is, was the eligibility software homegrown or purchased? Are you allowed to say what you implemented?
We did purchase it. It's a purchased service, and we use our clearinghouse software. We partnered with the same people that we partner with our clearinghouse.
Okay. And the second question is, what percentage of your patients use electronic statements?
It's pretty low. It's much lower than I would like to see it be. And to be perfectly honest, on the front end, we didn't push it much. I think that it was a little bit outside of our admission staff comfort zone. So they let people know that it was available, but we really didn't work hard to encourage people to sign up. We probably have about 10 to 12% of our patients today that have gone online and set up their process to receive those via their email. The way the process works for us is at the time of admission, we give them, they have to have sort of a secret answer to a secret question. We sort of developed a standard question that's something that every patient will know and can answer when they get back home. And so the process sends them, we sign them up when they're making their payment. We can sign them up right then when we are in the system to collect their payments or make their payment plans. We sign them up for electronic delivery. It sends them an email, and then it's incumbent upon the patient to complete that. So a lot of patients get the email, a lot of patients say yes when they're in the office, and they just never get around to it. Now, I think partly for us that's because we are a surgery center. We're kind of a one-stop shop for most people. Most people hope not to revisit us really often. And so once they have had that procedure, if we collect it appropriately up front, if they paid us what they think they owe us, then they're not anticipating really getting statements or getting many statements. We do not utilize that in our practice, but I think that it would be a bigger recurring group in our practice that would have the opportunity to know that they're going to get a statement every month. And so I think that's part of the reason we haven't seen as big a buy-in as I would have liked to have seen.
Okay, we've got one more question. It says, what denial software are you using?
Well, clearly we've gone all in with our clearinghouse because we're using the denial software with our clearinghouse as well, because that's where our remits come back through. We send our claims out there. Our remits come back through the clearinghouse. That's how we post them. And so they have already captured all of that denial information when the remits come back in. So for us, it seemed the most cost-effective route to go. We picked a clearinghouse that we have a good partnership with, and we vetted that piece out pretty heavily because we were going all in the full revenue cycle benefit. And so for us, we've sort of stayed with one partner for most of those products.
Okay, I think that's all the questions that we have, and our time is about to wrap up. So, Teresa, we just want to thank you again for the information. I'm sure everyone found it as beneficial as I did. And for all the attendees, if you'd like to check back on the website, we should have our February registration for our webinar open soon. Thank you.
Thank you. Have a good day.